We're really running out of time on this section, but I do want to discuss one important abstract. You know, maintenance therapy in AML. Basically, in no area of AML have we shown definitively that a maintenance therapy has improved outcomes. Even with the Ratify trial, the FDA said, you know, patients weren't re-randomized, so we don't really know the prognostic or the impact of maintenance midostaurin in that setting. Hypomethylating agents, a lot of people do that, but I'm not sure that does anything except make your patient come back month after month for treatment without a real benefit in survival. But there was a very important German study presented, the SOAR-MAIN study, looking at sorafenib for the prevention of relapse after allogeneic transplant for patients with AML with a FLT3 ITD in remission. Naval, you want to tell us more about that?
Yeah, I think this is a very important field, the maintenance, and like you said, you know, of course we were initially struggling to keep people alive, the elderly patients, and do new things, and now that we have a lot of tools, how we're going to build maintenance. So in FLT3, I think, is the area that has been the most intense research. With sorafenib, there have been phase 2 studies published by a number of groups, Dana-Farber, the Lebanese group, others, showing that, you know, if you do FLT3 inhibitor induction consolidation transplant, followed by maintenance, so total therapy approach, 75, 80, 85% even 3-year survivals, which of course 10 years ago when we first found out FLT3 was 20%, so this was very nice. But there was no randomized experience. So now the German group, who have done a lot of work with sorafenib, did a study where they took people who received induction consolidation, had transplant, and then post-transplant, you know, the question was maintenance with sorafenib versus just observation, which is what we do traditionally as a surveillance approach. And what they showed was that there was, number one, feasibility, because I think there's a lot of concern and questions about can you use sorafenib post-maintenance toxicities. And indeed, in most patients, at least in our experience at MD Anderson, we have to reduce the doses. So, you know, we have to go to 200 BID, whatever it may be. But in the end, they said it was feasible for the majority. There was not a lot of discontinuations. And of course, the most important punch was they had a very clear survival benefit with that maintenance approach. So based on that, at least in my opinion, we would be doing we've been doing maintenance anyways, but I think it will continue to be used. And there was another study, the RADIUS study with midostaurin, smaller numbers, phase 2 randomized, wasn't as clear. There was the trends, and they suggested that it, you know, may be beneficial, but I think we need more time. And then there's a third large study ongoing, which I think will be very, very important, with gilteritinib as maintenance in the post-transplant setting. And I think all of these data will hopefully consolidate it, but at this time we, you know, routinely do maintenance for these patients.
So,
yeah.
So some have said the gilteritinib placebo study should be closed based on the SOAR-MAIN data showing a benefit of sorafenib. But I have a feeling that the gentleman to my left may have a strong opinion on this.
Yes. So I was fascinated to watch the SOAR-MAIN data, and the feasibility issue comes up. A trial that took 6 years to accrue. You and I have given sorafenib. It makes your hands fall off and your feet fall off.
No,
and
no,
you
not
have
for
chronic
us.
diarrhea. Oh no, of course not. But nonetheless, 6 years to accrue a trial of only 80 patients, and this is something feasible. So while I have used sorafenib for many years, and in fact it was the impetus for investigating post-transplant FLT3 inhibitor therapy, that also was done in a population that has not received induction with midostaurin. Going into transplant with a deeper remission where you saw the much better outcomes in that patient population. The RADIUS trial, again, was kind of frustrating because really it did not reach statistical significance and didn't even try.
Right.
And
wasn't placebo-controlled.
Wasn't placebo-controlled,
Yeah.
was open to all manner of shenanigans, shall we say, in manipulation. So that's my objection. What, you know, in the modern era with the current treatments, what is the best approach post-transplant? And a good randomized trial incorporating MRD to decide who actually needs it. So my patients tell me, when can I go off my sorafenib? I can't walk, I'm on oxycodone from pain. Well, you can't. I don't actually have any study that tells me that. But the BMT-CTN 1506 study, which is actually half accrued, and we'll have that information, will tell us who needs it and for how long, using what I think is a vastly better tolerated, superior FLT3 inhibitor compared to
So I agree
sorafenib.
about
And we'll also look at things like MRD going into transplant, MRD coming out of transplant, serial monitoring to answer important questions like, what's the natural history of that? Because there is actually a placebo arm where we'll figure that out on an appropriately powered study.
I think this is the same problem that's going to happen with induction with our FLT3 inhibitors that we're going to talk about, quizartinib, gilteritinib studies, right? Once you have a drug approved, it is harder to say, and I actually think efficacy-wise, in fact, our fellow Dr. Alpha has presented this as an oral. There's no question about it. As single agents, quizartinib, gilteritinib are 10 times more potent to induce response than sorafenib or midostaurin. We don't have that data. Now our experience is very different. We've treated 200 plus people. Sorafenib is tolerable. We haven't had that severe hand-foot. But in the end, I don't think it's the one that's going to be used for efficacy reasons. Quizartinib, gilteritinib are, more important, we think.
Okay, so we're going to really have to move on. So, but as moderator, I'm going to take the prerogative of having maybe the last comment on this session. First of all, we don't even know what conveys the benefit of sorafenib or midostaurin, since they target so many kinases and they target FLT3, and all of this may have more to do with a graft versus leukemia effect than anything else. And so just substituting a more potent FLT3 inhibitor actually might miss the target in that population. I agree with your points about, it's going to be a different population of patients coming in. But remember what the German speaker said about the difficulty in enrolling that trial. Some doctors already felt they knew the answer and didn't want to put their patient on a placebo-controlled trial. And so the challenge the BMT CTN will have is, now we have even more evidence that sorafenib is there. Can you put your patient on a placebo-controlled trial? So I agree that the effort needs to be there, but you might be challenged to get the patients now.